Thank you. So surely there's going to be some overlapping between this talk and the previous ones, but still, I think it's always useful to listen to several points of view. These are my disclosures. Now, I'm sure that most of you have bumped into this kind of situation. That's a re-rupture of a cuff tear. And every time we see one of these, that reminds us that we have to be aware and familiar of all the risk factors and prognostic factors around cuff tears so that we can properly decide what to do to a cuff tear. Now, in ESCA, we tried some time ago to try and sum up some notions around this topic, and several chapters, like these three ones, tried to sum up and go over this topic, and much was written concerning this. And one thing was clear: there's a lack of evidence-based recommendations about this topic. So what surgical options do we have today? Well, besides the partial repair, which I think is a very good option, it can give good result in a midterm. You have augmented repairs with scaffolds, but unfortunately still not enough scientific data for us to use it in a systematic basis. Tendon transfers, we've been over that, cases with no arthritis, loss of external rotation, those that maintain some active elevation. SCR, for those cuff tears with no arthritis as well, may have some loss of elevations, can be an indication. The subacromial spacer that have been quite trendy in Europe, currently in the United States, but we also have some evidences today saying and stating that probably doesn't offer that much to the patient, one wouldn't know. And then the reverse arthroplasty that in cases of persistent pseudoparalysis definitely is the most predictable option. Now, tendon transfers. The latissimus dorsi transfer is a procedure I like a lot. It still remains the most time-tested transfer, so we must take this into account as well. It's best for young, active patients with no pseudoparalysis or previous surgery with a functional teres minor. So it can be better to restore the active elevation if you're considering a tendon transfer. On the other hand, lower trap tendon transfer, and I must say I have no experience with it, is better for those cases with an external rotation leg, with a deficit of a teres minor, again with no pseudoparalysis. So if you want to address the lack of external rotation, probably this is the way to go. And then SCR. Choosing the right patient is not always that straightforward. Indications should include patients till 70 years old, according to some surgeons. Probably I wouldn't go so far, but still it's an option. But you would have to have an intact or repairable subscap and an intact teres minor, and of course no arthropathy. But literature tells us that the failure rate can range from 3 to 36%, so there's a huge variability here. Lots of risk factors have been identified: female gender, overweight, subscap tears, a lower pre-op forward elevation, so we have to consider all this. So concerning the failure rate, and knowing the fact that depends a lot on the experience of the surgeon, the technique you're using, the type of graft you're using, we know today that the biceps is obviously an option. We've been over that in the previous talk, and we are aware of the advantages. But just take a look at this article from '74. This is not new. These authors proposed back in that time using the long biceps proximally attached to its origin as a pedicle graft. So in theory, they assumed it would provide an additional blood supply, so probably similar to the SCR, but perhaps just a different rationale. More recently, these authors tried to compare SCR using the long biceps or a dermal allograft, and they found clinical scores had improved in both groups, but the elevation was better when using allografts, but fewer complications when using the long biceps. Using an allograft came along with failure and complication rate that was around 35%, with more revisions and a poorer healing. But these authors used fascia lata for that comparison, and when comparing using fascia lata to using the long biceps for an SER along with a partial repair, both groups reached a pain and function scores that were significantly better but comparable. But scores, range of motion, acromial distance was better when using the long biceps along with a partial repair, although that was not significant. Now, this is just an example of long biceps being incorporated that you can see in the back. This is not necessarily an irreparable cuff tear, but definitely a fragile tendon where indication to reinforce and use the long biceps as an augmentation or SCR probably would be a good option. And as you can see, as you go inside the joint, the long biceps being used as a SCR and reinforcement of the long cable attached to its origin and the greater tuberosity. This is just another example, a larger tear. So long biceps as an SCR and partial repair of the infraspinated that's included and stitched to the long biceps, as you can see. And then the fasciolata, classical autograft. This is the way I harvest it. Much has been said concerning the morbidity, but I should say that the morbidity is not really a major issue. It's quite well tolerated by the patients, and this group from Lisbon has already showed that and published that. The morbidity is not such a big deal if you take proper precautions. And then putting it inside the joint for the SCR. This is how I've been doing it. I've changed my technique. I just called it Made It Easier, because it all started with a case in which I had done LD transfer a couple of years before, but it all failed due to an infection, so I had to get rid of everything. So I didn't have much room to place anchors in the greater tuberosity, and I decided to just use 2 anchors in the glenoid rim, and then 2 anchors in the lateral greater tuberosity. And for that, using those 2 anchors in the glenoid surface, and then using a double pulley system, just bring and transport the graft inside the joint. And as you can see, there's the tapes already stitched to the lateral margin of the fasciolata graft. And then as you go inside, tying the knots to fix the graft on the superior glenoid. This is looking from posterior. You will see the joint in a while. And then the next step will be going to the lateral room of the subacromial space, grab the tapes already tack stitched to the lateral margin of the graft, and fix them with a couple of punch-in lateral row anchors, knotless anchors in which you can estimate and tension the sutures, as you can see. So as you go midway, you can still pull on the tapes or sutures, whatever you're using, and reduce the graft to the desired location, and then complete the placement of the anchor by punching it in till the end, and then cutting the sutures, and final result, taking a look from lateral to from the subacromial space and checking on the proper location and fixation of the fasciolata graft into the greater tuberosity and the glenoid rim. And in this particular case, excellent result at 6 months, both in the shoulder and the thigh, with the lateral healing of the graft that I checked myself with ultrasound inside the shoulder. And now, this is a technique I developed from another technique that's been described using a dermal allograft, perhaps new kid on the block, which has as a rationale behind it, placing a graft in the undersurface of the acromion. So the point is using it as a spacer and perhaps also as a cushion to avoid that painful rubbing between the undersurface of the acromion and the humeral head. And this is the technique.
It is then prepared on a side table while removing all remaining fatty tissue, folding it 4 to 5 times and stitching the edges. The prepared graft should be approximately 4 times 3 centimeters in size with a variable thickness.
Increase the sound.
A crossed suture tape configuration with lasso loop knots at each corner is created by passing two broadband tapes from corner to corner sequentially, using a suture passer. The suture tapes are therefore locked to the graft corners, keeping it spread wide open when held under tension in a fashion that offers a good purchase of the graft, preventing it from sliding during delivery and subacromial fixation. The arthroscopic steps of the procedure are performed with the arthroscope from a posterior viewing portal and a standard lateral working portal with no cannulas. The scope can be switched to a lateral portal according to the needs. A needle is used outside in to locate the millimetric portals posterior and anterior to the AC joint. A suture retriever is then introduced through these portals to grab the corresponding tapes from the medial corners of the graft, previously transported to the subacromial space by a grasper, with the graft still outside the body. The medial tapes are pulled from the medial portals, and the graft, folded in half and held with a grasper, is introduced into the subacromial space. Once the graft is in place, the tapes from the other two lateral corners of the graft need to be passed through the skin close to the anterolateral and to the posterolateral corners of the acromion. A needle in an outside-in technique is used again to identify the proper location of the skin incisions, which, like the medial ones, should be beyond the limits of the graft to allow an effective pull in opposite directions, enabling a proper tensioning of the graft with no sagging. Once the four suture tapes are passed outside through the skin, the corresponding tails of each broadband tape with the same color are retrieved for tying. A suture retriever is introduced from the anterolateral acromial portal, then slid through the surface of the acromion and out through the opposite postural medial portal. The tape tail from this portal is retrieved back through the anterolateral acromial portal, followed by the same step with the other tape. The corresponding tape tails of the same color are then wrapped and tied around the superior surface of the acromion in a crossed fashion and using a knot pusher, ensuring the graft is properly positioned. Final construct is observed from a posterior and also from a lateral viewing portal, and the humeral head is seen bumping against the graft as the traction to the arm is loosened.
And this is the final look of the procedure. So as final messages, there are clearly no guidelines for an appropriate management of massive rotator cuff repairs today. Unfortunately, there's a low quality of evidence in many of the studies out there, and definitely many of the techniques we decide to do are largely based on personal experience and extrapolated scientific data. And if you like this subject, do not forget, just a reminder, do not forget the JESCA Specialty Days in November. That's going to take place in Warsaw. Thank you.